George's medical history is not noticeable prior to the accident. After the head-on collision, it was followed by 24 hours of post-traumatic amnesia. He scored only 9 of 15 on the Glasgow Coma Scale, and he obtained major damage to his frontal lobe and controcute damage to the back of his brain. This resulted in a diffuse subarachnoid hemorrhage, causing a traumatic brain injury that continues to this day for George. His social history is that he's 40 years old, he's married with family, and he was employed full-time and now has problems staying employed. His results showed that the 9 out of 15 on the Glasgow Coma Scale really doesn't tell us much information because we don't actually have the breakup of which area he had his biggest problems in at the time. But we can look at his SCATB results, and which is the scales of cognitive ability in traumatic brain injury, showed problems with sequencing of events, word generation, recall, and memory, as well as reasoning. His lower function raw score was 99, while his higher function raw score was just 64. His total SCATB raw score was 163. The combination of particular low subscores in reasoning and the contrast between his lower and higher functioning raw scores point towards George having issues with his executive functioning. Speech samples showed that he exhibited frequent random topic changes without awareness of the communication partner's needs. It was very self-focused, and his sentences sometimes had a simplistic structure and at times an incomplete syntax. Key issues for George are poor conversation skills with frequent and unrelated topic changes, and this is enhanced by poor self-awareness. Overall, it creates difficulties in social and work situations which are exaggerated due to poor executive functioning in areas of difficult concentrating. George has also difficulties with multitasking, staying organized, his time management, and developing new ideas. So the combination of that plus his discourse problems in a pragmatic area really create a lot of difficulties for him. The speech and language issues are not that present outside of word finding difficulties. Overall, it creates a high level of anxiety for him. George's key strengths, however, are that he remembers small amounts of new information, he maintained his old knowledge, he manages social situations okay in one-to-one settings, works better than in groups for him, and he has a good attention span. He's able to problem solve in a relatively complex task. And these, especially the last two, the attention span and the complex task problem solving, were really relevant in choosing his treatment. Overall, his diagnosis is that he has a cognitive communication disorder due to a traumatic brain injury. His treatment is that metacognitive strategy instruction, MSI, also known as metacognitive skills training, to improve his topic maintenance and discourse pragmatics. The reason this was chosen is because George has a cognitive communication impairment, which means his problems are not on a speech or word level, but on a pragmatic level. Canizaro et al. States in the article on the treatment of discourse deficits following a TBI that discourse is at the important intersection between attention, memory, organization, and executive functioning and language. This really relates to all the deficits that George showed in his SCATB results. Further, they conclude that metacognitive strategy instructions can improve discourse measurements for clients with TBI. George showed signs of lacking cohesion and coherence in his speech samples. For example, he does not link his different topics, but rather jumps from one to the next. Hence, he struggles with topic maintenance. Metacognitive training is a teaching strategy that can be used with adults with TBI if they have some level of self-awareness and also present a good attention span and ability to solve complex tasks. Therefore, George is a good candidate for this metacognitive strategy instruction. MSI method was used to set up a program to improve his topic maintenance and discourse pragmatics. It was combined with external aids and prompts and works well because the goals are functional and meaningful for him in his daily routines. The systematic review by Mary Kennedy et al. On the intervention of executive functioning after traumatic brain injury showed that metacognitive strategy instructions improve executive function and concluded that MSI should be a practice standard for young to middle-aged adults with TBI. At 40 years of age, that is exactly where George sits. Mackay et al. States that metacognitive training with verbal self-instructions can be used to improve executive functioning after TBI to improve attention and working memory. The MSI was chosen for George because it's evidence-based, it addresses his area of greatest needs in executive functioning and social communication, which is relevant to his family and work participation. It's a flexible strategy that can assist to learn relevant skills that are easily stepped up or down to adjust the progress that he makes. The same methods can be used by other professionals, for example his OT, to teach George skills that fall into their domain of practice. I believe that the consistency in methodology in teaching for George would lead to a better generalization, especially since the underlying target in his poor executive functioning, which really affects his daily tasks, for example time management and multitasking, and therefore the metacognitive strategy instructions will really assist him.